Assalamu alaikum and good morning. So this video is especially being made for the medical students and young doctors. Sometimes it gets a bit difficult to differentiate between an organic case or the presentation is either psychiatric or organic, or the presentation has underlying neurological or medical causes. So there are some hints which I would like to emphasize in this video that a boy presented to me in clinic with tuberous sclerosis. He was referred by a pediatric neurologist. He had epilepsy and he was being managed for the epilepsy issue. Meanwhile, he also had OCD-like symptoms. When he presented to my clinic, I explored his OCD symptoms. He did had that OCD symptoms. Obsessions were intrusive. He was unable to stop, and he was quite shy to reveal these symptoms to others. So in children, we have to be very vigilant that children do not reveal their feelings like adults do. And secondly, he was unable to suppress those feelings, and he was able to tell me about images, that he is able to see some image which is quite distressing, and that image also creates some thoughts in his mind which he is unable to stop, and then he does some compulsive behaviors. So now, first of all, we have to see that either there are some dysmorphic features or not, right? Shape of nose, shape of eyes, shape of ears, or are there some spots, as that child had some kind of spot here. I'm not an expert neurologist to tell you more details on those spots or the dysmorphic or the morphological features of tuberous sclerosis. But as far as behavioral aspect is concerned, it becomes very tricky to differentiate OCD from psychotic symptoms. But it took me a while, almost around 15 to 20 minutes, to differentiate that definitely he has OCD symptoms and this is not something psychosis. He didn't had auditory hallucinations or delusional perception, delusion of thought insertion, withdrawal or broadcast. So he lacked those symptoms, but one thing which he was telling me looked like that he has some visual hallucinations, but those were obsessional images which he was unable to stop with. So meanwhile, his other workup was under process, but we started with the treatment of OCD symptoms, and then we also made him to learn about thought stopping technique. So take home message here is that when such presentations come, we do not have to label them that they are primarily psychiatric. We always have to explore medical and neurological basis behind them. We also have to remember that psychiatric illnesses carry a lot of stigma, and sometimes it becomes very difficult for families to digest that information. So cultural sensitivity should be there in our practice, and rest of other parameters that some other healthcare professionals, some other experts should also be a part of the management plan, and then we should liaison with that team, and then sometimes we can do CMEs on such cases so that we can learn more and more. So I thought to convey this message via this platform. With this, I would like to end here. Take good care of yourselves. Allah Hafiz.